Welcome to the Hearing Review's webinar, Hearing Loss and Associated Comorbidities, What Do We Know?, presented by Harvey Abrams, PhD. I'm Carl Strum, editor of the Hearing Review magazine and its website at hearingreview.com. In only the last 5 to 10 years, a large number of important studies have surfaced linking hearing loss to a variety of disabling conditions such as cognitive decline, depression, diabetes, falls among the elderly, heart disease, and much more. Today's webinar reviews the most eye-opening of these scientific studies and summarizes their findings so that hearing care professionals, as well as doctors and primary care physicians, can use them to foster more informed and impactful patient counseling, as well as for more patient referrals. The growing awareness of age-related hearing loss as a public health concern represents a monumental opportunity for hearing care professionals to touch the lives of more patients who need hearing help. Dr. Abrams is a very well-known and highly regarded audiologist, researcher, and lecturer in our field. He's perhaps best known for his work at the Department of Veterans Affairs, where he served as the Chief of Audiology and Speech Pathology Services at Bay Pines VA Healthcare Center in Florida, as well as serving as Director of Research at the Army Audiology and Speech Center at Walter Reed Army Medical Center. Dr. Abrams is a frequent contributor to the Hearing Review and many other publications and has a comprehensive view of audiology in the hearing industry, having served as Director of Audiology and Research at one of the largest hearing aid manufacturers in the world and now consulting for the Better Hearing Institute and the Hearing Industries Association. Our webinar sponsor is Hamilton Captel. Since 2003, Hamilton Captel has connected individuals who can't hear on the phone with their family, friends, and hearing healthcare professionals. The experience of being able to read while listening to what's being said on the phone provides clarity and confidence, which is why so many people with hearing loss rely on the Hamilton Captel captioned telephone to stay connected and stay healthy. Right now, through the Hamilton Captel Hearing Healthcare Program, you can certify your qualified patients to receive the Hamilton Captel phone at no cost. For more information, call 1-800-826-7111 or visit the email address shown here. As a matter of housekeeping for today's webinar, you can email Dr. Abrams and me questions via the Q&A box on the left or by using the email address shown at the end of this presentation. I am also obligated to point out the standard ever-present legal disclaimer, which essentially says you are urged to consult with financial, legal, and other advisors relative to this content, and there's no implied liability for the use of the information provided. And with that, I'd like to welcome Dr. Harvey Abrams to today's Hearing Review webinar. Dr. Abrams?
Well, thank you for that kind introduction, Carl, and I would like to thank Hamilton Captel for their generous support in sponsoring this webinar. In the interest of full disclosure, I provide research consulting services to the Hearing Industries Association and Better Hearing Institute, Starkey Hearing Technologies, and Creari Incorporated, for which I receive consulting fees. I have no non-financial interests to disclose. I'm sure you're all aware of the recent and frequent reports in the lay press linking hearing loss with a number of conditions, including falls, dementia, and depression, for example. This linkage is often referred to as comorbidity. Comorbidity can be defined as the simultaneous presence of two chronic diseases or conditions in a patient. It's interesting to note how the frequency of the term comorbidity has increased in recent years. What then is a chronic condition? Wikipedia defines it as a persistent or long-lasting health condition or disease. Those disorders that persist for more than 3 months are considered chronic. Under that definition, hearing loss would clearly qualify as a chronic condition. I would argue that it shares many of the same characteristics as diabetes, for example, a common chronic health condition in this country. For example, both are invisible, they're progressive, they're painless, both are often incurable, they are treatable. Professional expertise is front-loaded, and what I mean by that is that much of the professional intervention occurs during the first few patient encounters. Self-managed behavioral change is required for long-term success, and both we've seen when collaboratively self-managed, patient experiences reduced activity limitations, participation restrictions, and increased quality of life. As noted earlier, the popular press has picked up on some of the comorbidities associated with hearing loss. The purpose of this webinar, however, is to review the research literature that supports the associations between hearing loss and other chronic conditions. Due to the limited length of this presentation, I will focus on the conditions listed here and limit the supporting evidence to 1 to 3 published papers per condition. As a matter of interest, here's a list of additional conditions that have been linked to hearing loss, which I won't be reviewing. I will, however, briefly review one interesting article on mortality. Bet you didn't think hearing loss could kill you. Before we get into the research, let's review the extent of hearing loss in our country. Here's some data reported by Agrawal and colleagues on 5,742 individuals who participated in the audiometric component of the National Health and Nutrition Examination Survey, or NHANES, between 1999 and 2004. The overall prevalence of bilateral hearing loss for those between 60 and 69 was about 27%. For those between 70 and 79 was 55%, and for those 80 and above was 79%. If we include unilateral hearing loss in the prevalence data, the rates are considerably higher for each cohort. The psychosocial consequences of sensory neural hearing loss that seriously compromise audibility and speech intelligibility should be well known to you, and these include withdrawal, isolation, reduced quality of life, depression, and cognitive decline. I've proposed a model here that illustrates the possible sequela of events that progress from hearing loss, which negatively impacts speech perception, leading to increased communication effort and reduced social engagement, with consequences for cognition, physical functioning, and health-related quality of life. As I review the literature, I will be referring to some terminology that is common in large population or epidemiological studies. So let's define those here. Odds ratio is the odds and an outcome. For example, falling will occur given a particular exposure, an example being hearing loss, compared to the odds of that outcome occurring in the absence of that exposure. So here's an example. The odds of falling is twice as likely among people with hearing loss than people without hearing loss. Now, I'm not saying that is the odds, but that's sort of an example. Risk ratio, which is also referred to relative risk, is the cumulative risk of a particular outcome occurring over a particular time span. So here's an example. At the end of the study, let's say 10 years, the risk of having dementia without hearing aids is twice that than with hearing aids. And then finally, you'll hear me talk about hazard ratio, and that is the risk of an event occurring at a particular time. So an example here is the risk of having hearing loss if an individual has cardiovascular disease is twice that compared to an individual who does not have cardiovascular disease at 5 years post-diagnosis of CVD. You will also hear me refer to adjusted odds ratio or adjusted hazards ratio. In this context, adjusted means that the data has taken into account other confounding variables that might be responsible for the effect. For example, older people have hearing loss. So if we find that people with hearing loss tend to fall more than those with normal hearing, couldn't fall simply be the effect of aging and really have nothing to do with hearing loss. Specific types of statistical treatments allow for the removal of aging, in this example, as a factor in the analysis so that hearing loss can be examined as an independent risk factor associated with the outcome of interest. Let's start with social isolation and loneliness. What does the evidence say about the link between hearing loss and social isolation and loneliness? While these are often treated as separate constructs, I will be combining the two here. Here is a 2016 study by Sung and colleagues who examined those factors associated with loneliness among 145 participants enrolled in the SMART study. SMART stands for Studying Multiple Outcomes After Oral Rehabilitation. Kind of a cool name. Between the years of 2011 to 2013. Loneliness was measured using the UCLA Loneliness Scale. The researchers found that younger age and greater hearing loss were significantly associated with greater loneliness. Other psychosocial factors, as measured by the Medical Outcome Survey, short form 36, also known as MOS SF36, as well as measures of depression, quality of life, mental health, and emotional well-being, were also associated with hearing loss. Here's a fascinating study by Nancy Donovan and her colleagues, who investigated the relationship between loneliness and cortical amyloid burden in cognitively normal older adults. Many of you are probably aware of the link between the presence of amyloid plaques in the brain and Alzheimer's disease. The researchers found that after controlling for a number of other factors, higher amyloid burden was significantly associated with loneliness as measured by the UCLA loneliness scale. Those in the amyloid-positive group were 7.5 times more likely to be classified as lonely than non-lonely. Here is an illustration of the findings. On the x-axis is the adjusted amyloid burden as measured by positron emission tomography, and on the y-axis are the adjusted UCLA loneliness scale scores. The analysis shows a possible relationship, or rather a positive relationship, between the two measures. So, given the two studies reviewed thus far, we see the links between hearing loss and loneliness and cortical amyloid burden. Could hearing loss then be a contributing factor leading to elevated cortical amyloid burden? Next up, depression. Here's data from the 2005, 2006, and 2009, 2010 two-year cycles of the NHA-NES involving 1,029 individuals 70 years of age and older. Depression was measured by the Patient Health Questionnaire, or PHQ-9, a self-assessment measure. Results indicated that the odds of self-reporting a major depressive disorder was 1.5 per 25 dB in the better ear. The odds of self-reporting any depressive symptom increased to 1.63 per 25 dB. The results suggested that hearing loss was independently associated with depression. Similar findings were reported in this 12-year 2000 to 2011 review of the Taiwan National Insurance Research Database, which included 5,043 patients with sensory neural hearing loss and 20,172 patients without. The analysis revealed that the risk of depression was higher in the hearing loss cohort, the hazard ratio being 1.73, again suggesting that hearing loss is an independent risk factor associated with depression. Here is an illustration of a time-to-event analysis with time to a diagnosis of depression represented on the x-axis and the cumulative incidence of depression on the y-axis. So, taking 8 years as an example, we can see that the incidence of depression for those with hearing loss is approximately 0.035 compared to those with hearing loss, which is a little over 0.06. Here's another look at the relationship between depression and hearing loss. Using data from 18,318 individuals who participated in the NHA-NES from 2005 to 2010. These data are a bit more nuanced as the researchers were interested in examining depression as a function of the severity of hearing loss. And there appears to be a direct relationship between the two, with the odds ratio for moderate to severe depression increasing as self-reported hearing progresses from good to a lot of trouble. On the left side of this slide, we see the relationship between the presence of self-reported hearing difficulty and the degree of depression as a function of gender. Prevalence is represented on the y-axis. Mild depression is in light blue, and moderate to severe depression is in dark green. For both men and women, the prevalence of depression increases in the presence of hearing loss. The right side of this slide illustrates the same relationship using objective measures for both men on the top graph and more so for women on the bottom graph as PTA increases, which is represented by the light blue bars. Depression, as represented by the dark squares, also increase. This trend is more obvious for women. Again, light blue bars representing the PTA and the dark squares representing the results of the PHQ-9. The exception to this were individuals who reported themselves as being deaf. On to falls, so watch your step. As many of you are aware, falls in the elderly population represent serious economic and health concerns, which often result in fatal outcomes within the first 12 months following a fall with injury in this population. Lynn and Ferrucci examined the association between fall and hearing loss among 2017 NAH-NES participants from 2001 to 2004 and found a significant association between the two with a 1.4-fold increased odds of reporting a fall in the previous 12 months for every 10 dB of hearing loss. Adjusting for demographic, cardiovascular, or vestibular factors did not significantly change the magnitude of the association. So what do we know about the relationship between hearing loss and cardiovascular disease? This interesting study by Friedland and colleagues revealed that the audiometric patterns, particularly low frequency and flat, are strongly correlated with cardiovascular disease. The pie chart in the upper left of this slide provides the color code for the distribution of audiometric configurations discussed here. Pay particular attention to the red, which represents strial or flat, and orange, representing low-frequency sloping hearing losses. For example, low and flat losses are associated with 75% of diagnosed coronary vascular disease cases in this cohort of 1,168 patients. In terms of CVD events, the second pie chart on the second row indicates that about 80% of diagnosed strokes were associated with individuals with flat or low-frequency sloping losses. The authors posit that this association may reflect either a common vascular pathology within the vertebrovascular system or a generalized vascular compromise affecting both hearing and cardiovascular structures. I'm going to now review some of the research linking hearing loss and diabetes. Meta-analyses can often reveal effects that are obscured in individual studies, particularly those with small sample sizes. This systematic review analyzed the data from 13 eligible studies involving 20,194 participants and 7,377 individual cases. The meta-analysis revealed that the prevalence of hearing loss among those with diabetes was more than twice that of those without diabetes. The association between hearing loss and diabetes was stronger in those younger than 60 years of age, but was independent of gender or chronic exposure to noise. Here we see the odds ratio for each study represented by the black boxes. The lines represent the 95% confidence interval. The diamond at the very bottom represents the pooled odds ratio for all of the studies, calculated at 2.15. The authors concluded that the meta-analysis indicated a significantly higher prevalence of hearing impairment in patients with diabetes compared with that in non-diabetic people. Moreover, the finding was independent of the effect of aging or noisy environments. Here are the results of a population study evaluating the association between hearing loss and diabetes among 5,140 participants in the NAH-NES from 1999 through 2004. Consistent with the other studies I reviewed, hearing impairment was found to be more prevalent among those participants with diabetes. Following multivariable analyses, it was found that people with diabetes had significantly increased odds of hearing impairment in worse and better ears at all levels and severity of and frequency. Highlighted here are the odds ratios and confidence intervals for just the better ear as a function of degree of hearing impairment and focus and frequency. The association between diabetes and hearing impairment was independent of known risk factors for hearing impairment such as noise exposure, ototoxic medication, and smoking as examples. In this prospective cohort study, over 253,000 adults with baseline normal hearing were followed from 2002 to 2014. Among these 253,000 participants, the hazard ratio for developing hearing loss, adjusted for noise exposure, body mass index, smoking, alcohol use, and exercise, was 1.04 among those with prediabetes and 1.4 for those with diabetes. In this time to event graph from Kim et al., and using 6 years out as from baseline as an example, the cumulative prevalence of hearing loss was about 0.01 for the non-diabetic participants and approaching 0.06 for the diabetic participants. The authors posit that the vascular effects of diabetes damage the blood supply to the cochlea, leading to sensorineural hearing loss. The relationship between hearing loss and dementia has perhaps received the most attention, at least among those in the hearing healthcare community. So let's explore this research. Perhaps the landmark study that elevated the professionals' and public's interest in this relationship was conducted by Frank Lin and colleagues and published in 2011. The researchers prospectively studied 639 participants in the Baltimore Longitudinal Study of Aging Project who were dementia-free in 1990 to 1994 and followed them for a median period of just under 12 years. During this period, 58 cases of incident all-cause dementia were diagnosed, of which 37 cases were Alzheimer's disease. The risk of incident all-cause dementia as well as Alzheimer's disease increased with the severity of baseline hearing loss. The table on the left side of this slide illustrates the unadjusted hazard ratio for increased degrees of hearing loss. After adjusting for other contributing factors, the results illustrated on the right side suggest that hearing loss was independently associated with incident all-cause dementia, and that the risk increased as a function of the degree of hearing loss. The risk of incident Alzheimer's disease also increased with baseline hearing loss, a hazard ratio equaling 1.2 per every 10 dB of hearing loss. In a similar prospective population-based study, Virgo and colleagues followed 4,463 individuals who were dementia-free at baseline. Consistent with the Lin study, the results indicated that hearing loss was an independent predictor of developing dementia. This time-to-event graph illustrates the data in a slightly different way than we've seen before. The y-axis represents cumulative survival, which in this case means absence of dementia. The higher the number, the fewer cases dementia. So 1.0, for example, means that 100% of the cohort is dementia-free, which in fact was the case at baseline. The x-axis represents time to dementia. So looking at 10 years out from the dementia-free baseline, for example, we can see that the cohort without hearing loss had a cumulative survival rate, that is a dementia-free rate, of approximately 0.85, whereas the hearing loss cohort had a cumulative survival rate of about 0.7, indicating that fewer individuals with hearing loss were dementia-free after 10 years following baseline. This large longitudinal epidemiologic study used a sample of 154,783 persons aged 65 and older from claims data from the largest German health insurer. They then followed these participants between the years of 2006 and 2010, during which time 14,602 incident dementia diagnoses were made. Gender, age, and comorbidities were controlled for as potential confounders. and patients with bilateral hearing impairment had higher risks of dementia incidence than patients without hearing impairment. This is a particularly compelling illustration of the results. You should be familiar with time to event graphs by now. Looking 4 years out from baseline, where all cohorts were dementia-free, the percentage of individuals with no hearing loss and no depression are depicted by the blue line. The percentage of individuals with hearing loss and no depression is depicted by the solid green line. And remarkably, the percentage of individuals with hearing loss and depression, as depicted by the dashed green line, dramatically illustrate the combined effects of hearing loss and depression on dementia. There have been a number of theories proposed to explain the relationship between hearing loss and dementia. The model proposed here by Wayne and Johnsrud makes a lot of sense to me. They theorize that there is an interaction between bottom-up processing and top-down processing, represented by these two paths, which combine to create the perceptual difficulties, challenges to cognitive resources, and negative psychosocial outcomes, and ultimately impaired cognition. So let's get back to the model I presented earlier in the talk. Given what we now know from the literature we reviewed, I added loneliness and depression to the model and dementia as a potential consequence. So if all of those comorbidities were not enough, it turns out that there may be a relationship between hearing loss and mortality. The Reykjavik study reviewed here involved 4,926 Icelandic individuals enrolled in a large epidemiological study who received hearing examinations between 2002 and 2006 and who were prospectively followed for mortality through 2009. It turned out that individuals with hearing loss had a higher risk of death resulting from cardiovascular disease than those without hearing loss. Here are some data from that study. Looking at our time to event graph, event here meaning death from all-cause cardiovascular disease, we can see that males with no or mild hearing loss experienced higher survival rates than those with hearing impairment who had higher survival rates than those with both hearing impairment and visual impairment or dual sensory impairment. But the story is not all bleak. It turns out that amplification may have some positive mitigating effects on some of these comorbidities. Here's an interesting study by Rumala and colleagues that indicated that using hearing aids for 30 days may in fact reduce the risk of falls. The experimental condition involved measuring the amount of time the participants maintained stability on the Romberg and tandem tests. Each of the lines here represent the unaided and aided performance of an individual participant, and the higher the number, the longer the individual is able to maintain stability. For many participants, the number of seconds they maintained stability significantly increased following hearing aid use. A possible explanation for this effect might be that the brain utilizes sound cues to improve spatial orientation. That is a three-dimensional sound map, which in turn results in improved postural stability. You may recall this study I reviewed earlier, which supported the relationship between hearing loss and depression. When the investigators looked at those individuals who were wearing hearing aids, their odds ratio of being diagnosed with major depressive disorder or reporting any depressive symptoms were significantly lower than those who did not wear hearing aids. Boy et al. Conducted a prospective study involving 15 participants that supports the effects of hearing aids on reducing depression. On the left side of this slide, we see the reduction in both depression scale and caregiver burden inventory scores over the 6 months following hearing aid use. On the right side of the slide, we see changes in the MOS SF36 scores over 6 months, with a particular focus on the mental health score. The dotted line represents the mental health score at baseline, And the solid line represents the mental health score at 6 months. Further from center, the higher or better the score. Barbara Weinstein and colleagues investigated the effects of hearing aid use on loneliness. They were able to document a significant decrease following 4 to 6 weeks of hearing aid use on both the total score and the emotional loneliness subscale score using the Dijon-Geveld loneliness scale. In terms of the effects of hearing aids on cognition, Piers Dawes and colleagues found that hearing aid use had a positive effect on cognition, which was independent of isolation and depression. Similarly, Akar et al. Found improvements in cognitive status after 3 months of hearing aid use. Figure 1 illustrates significant improvements on the MMSE score following 3 months of hearing aid use. Market Track 9 data has also revealed self-reported psychosocial benefits of hearing aids. For example, hearing aid owners report being significantly less bothered by experiencing little interest or pleasure in doing things than non-owners, or even those who didn't report hearing difficulty at all. Hearing aid owners reported feeling less down, depressed, or hopeless than non-owners, even more so than those who reported no hearing difficulty. The MT9 data also indicated that hearing owners reported being less forgetful in the past year than non-owners. What might explain the benefits of hearing aids on these psychosocial measures? The evidence is fairly compelling that the auditory system is neurophysiologically plastic. An example is a study here by Kevin Monroe, which was published in 2008. And the Levy et al. 2015 study made a strong case for auditory plasticity by examining changes in auditory processing tasks following hearing aid use. If we accept that the auditory system is plastic, we can envision how hearing aids might influence the Wayne and Johnsrud model by providing enriched upstream auditory information to the brain, which in turn may mitigate downstream consequences associated with increased cognitive load and compromised psychosocial outcomes in the unaided condition. So the research evidence truly points to associations between hearing loss and specific chronic conditions and the potential positive impact of audiologic rehabilitation on those associations. What is critically needed, however, are carefully designed, randomized controlled studies so that we can better understand the nature of those associations and implement effective evidence-based interventions. One large-scale study in the works is headed by Dr. Frank Lin, named the ACHIEVE study. Its aims are to determine the effect of best practices hearing rehabilitative treatment on rates of cognitive decline in 70 to 84-year-old, well-functioning and cognitively normal older adults with hearing loss, and to investigate the mechanistic pathways through which hearing rehabilitation treatment affects cognitive functioning. The feasibility phase of this study has been completed, and the full project grant proposal has been approved by the National Institute on Aging. Another ambitious study is underway in the EU involving some 7 nations across Europe. Among its many aims is to gain a better understanding of the links among hearing, vision, cognitive, and emotional systems. What then does this all mean for the clinician? I would suggest that if you're not already doing it, you should be routinely screening for cognitive disorders in your older patients. There are some very helpful reviews, including this article by Robert Sweeto that appeared in Audiology Today in the summer 2015 issue. Doug Beck and colleagues also published a helpful review of cognitive screening tests in a 2016 Hearing Review article. This recent tutorial by Jing Shen et al. Provides a comprehensive and useful overview of the issues associated with mild cognitive impairment in older adults and available screening tools for the audiologist. Screening for depression should also be added to your comprehensive evaluation. Now, most audiologists are likely unaware of the available screening tools for depression, and may be somewhat uncomfortable screening for this disorder, there are, in fact, a number of useful and easily administered screening tools available. I thank Bob Pfeiffer for posting this list in a recent AAA listserv post. Whether you agree or not that you should be performing depression screening, it is in fact required as part of your TINIS evaluation per the Physician Quality Reporting System guidelines. That is, if you expect to receive full reimbursement for conducting 92625 procedures. So the takeaway message from this presentation is that, contrary to what is assumed by many in the healthcare community, age-related hearing loss is not a benign condition. A cautionary note, however, as none of the research that I've reported has yet supported a causal relationship between hearing loss and chronic conditions such as depression and dementia. So it would be irresponsible and unethical for you to suggest to your patients that the science indicates otherwise. What can you do tomorrow with this information? Well, ask your patients about the conditions we reviewed today and read the literature, both peer and non-peer reviewed. Keep yourself up to date on the research in this area, which is changing very quickly. Also, establish a network of specialists to whom you can refer your patients. If you expect serious or cognitive or psychosocial disorders following screening, you want to make sure you have an appropriate professional to refer your patient to. So with that, this concludes the presentation. And if you have any questions about the research that I reviewed, feel free to contact me at this email. So thank you very much for your attention, and let me know if you have any questions.
Thank you for that great information, Dr. Abrams. Harvey Abrams, PhD, is the former Chief of Audiology and Speech Pathology Services at Bay Pines VA Healthcare Center in Florida, as well as Director of Research at the Army Audiology and Speech Center at Walter Reed Army Medical Center, and he now serves as the Senior Audiology Consultant for the Better Hearing Institute and the Hearing Industries Association. If you have any questions for Dr. Abrams, you can email him at the address shown here. This webinar was brought to Hearing Review courtesy of Hamilton CapTel, a company that offers captioned telephones to stay connected and stay healthy. For more information about their great offerings, you can visit them at hamiltoncaptel.com/HHC. I'd like to thank Dr. Harvey Abrams and Hamilton CapTel for their participation in this webinar, and also Hearing Review staff members Eli Patterson, Tess Skilling, and Roy Feltz for their help in producing it. For the Hearing Review, I'm Carl Strum. Thanks for watching.